Hello, everyone, and welcome to today's webinar. This is Paul Marquis, PT.
And I am Dr. Susie Lachowski-Glass.
And today we're going to be talking to you about blood flow restriction training, and we're going to give you just kind of a brief overview so you have a better understanding of what it is. We'll talk a little bit about the history, some physiology, different types of bands and whatnot, but we're going to give you just a brief rundown today so you have a better understanding so that you can work your way into becoming more confident in doing blood flow restriction training with your patients or your clients, and so that you just feel more comfortable doing it. So I first of all want to start by thanking all of you who are watching today, who may have come to some of our live courses, and we've had such a great time with that. People have hosted courses. We've gone over and just gone through the whole thing from top to bottom, from physiology into the practical application part of it. And those are really fun. So what I want you all to do today is, make sure you stay till the end. We have a nice little coupon code for you to use if you do decide you want to jump into some sort of a course in the future. So Susie, let's start with a little bit of the history. Where does blood flow restriction training come from? Who invented this, and why are we doing this now?
Yeah, no, sounds great. This entire modality really came from Japan in the late 1960s by someone named Dr. Sato, and it's actually coined katsu training through them, which in Japanese just means additional pressure. So their terminology, we'll go through all the various terminology because some people like to use blood flow modification training, blood flow restriction training, and there are some differences and nuances speaking with regards to the application and the physiology, which we're not going to get too nitty gritty today on, but just wanted to let you know there's a lot of different terminology out there. And the katsu training does like to use the blood flow modification training terminology. Me personally, if I were to deem this modality, I would have probably named it hemodynamic alteration training, a little bit more scientific, and it's just easier to explain from a physiologist point of view to someone else, because once in a while, someone will think, oh, blood flow restrict, that word restrict and blood and all in the same terminology can kind of be a little scary or off-putting to someone, especially if you don't know what the modality is. But it did come from, Dr. Sato had an epiphany in Japan in the late 1960s where he, used various amounts of pressures on himself after an injury, and he was a bodybuilder and all of those other kind of things, and ultimately figured out a way to alter blood flow patterns to get a lot of musculoskeletal physiological responses that occur. There's a lot of aerobic responses that occur as well. But ultimately, this really originated and really got its start in Japan a few decades ago.
Yeah. Now, I'm going to go back because you mentioned blood flow restriction, and this is how we got together. Susie and I kind of connected. It was about 5 years ago. I had a patient who she was stuck. She just had this retropatellar chondral lesion and had surgery, and she just wasn't advancing in her rehab. She just was having a lot of discomfort. We just had a hard time pushing her and loading her enough to make a difference. And so I spoke to her surgeon, Dr. Christian Latterman from Boston, and he had done the surgery, and he asked if I'd ever done blood flow restriction training before. I said no. He connected me with Susie, and at that point, Susie and I had a little discussion about it. I was still a little skeptical and worried and afraid to use it because of what it was called and how it worked. So we had that discussion. I did go through the training with Susie. After about 7 hours of everything we're going to be talking about in a nutshell today, I felt much more comfortable, much more confident, left there, started using it right away. And I've been using it for the last 5 years with a number of patients. And just one of the things I need to tell you is that it is a little scary at first because of what it was named and how it was named. But once you become familiar and you understand how it works, and you become familiar with all the different types of systems out there, and you get into the physiology and you use it on yourself, it really becomes much easier to use. You'll feel much more confident, and your patients will get a lot of benefit out of this. So, I just wanted to bring us back to that because it's fearful for some, but once you learn about it, it really shouldn't be. So
Great.
now, let's just talk a little bit about, we see these blood flow restriction bands on people's arms and legs. they typically get fitted, on the proximal arm, proximal thighs, just just near that gluteal fold, in the groin as close as possible. And those are really the four areas that you would put it on most oftentimes. Um, Now, let's talk a little bit about the physiology behind this. I mean, we can't put 8 hours into 45 minutes here, but let's just talk about that a little bit, because there is this preconception that you put a band only on the side that you have an injury on, right? And so, Susie, if you could explain a little bit about the physiology behind it so that it's easy to understand, and we can move forward from there.
Yeah, no, absolutely. So, Paul, already explained pretty much, it's pretty much two locations you're going to want to put either, the blood flow restriction band, or, sometimes depends on what category we put the bands or the cuffs into. It might be more of like a cuff-like material. You're going to put it proximal on the extremity. So pretty much up as high as you could go on the lower extremity below your gluteal fold, on the upper thigh, and then up on the upper arm, right below that, around that deltoid insertion there. So, not in the middle of the muscle bellies. We don't want to impede muscular movement as much. But the whole premise of this is, and for me, as a physiologist, I've been working with blood flow restriction training and Katsu training for over 10 years now, between research, application, teaching, education. The hardest thing for me to ever do is always usually summarize something in a minute for you guys, but I'm going to do my best to summarize this to give you a really good overview of really what this modality is doing. So when you place the band on the on the upper extremities, or on the upper extremity, or lower extremities, what you're going to be doing is adding varying amounts of pressures in. We'll get a little bit into the application in just a second, of the different types of bands and how you would go about that. But the whole point is we're either going to restrict or alter blood flow patterns. So when we're altering blood flow patterns, we definitely really want to be restricting or altering, especially the venous outflow of the muscle bellies. Okay. And when we do so, we're creating venous pooling in our capacitance vessels. And what ends up happening is we're building up a lot of metabolic waste. So we're going to be lifting low loads or low intensities, not heavy weights. So what we're going to be doing by altering or manipulating blood flow patterns is we are going to then restrict the waste being cleared. So when we're restricting the waste being cleared, what ends up happening is, in a very quick nutshell, is that we have to start activating bigger muscle fibers to keep exercising, even though we're using low loads. So our type 1, our aerobic muscle fibers love oxygen, love, that aerobic endurance type of nutrients, and so forth, to keep exercising. However, if we're clearing less waste, what we're going to have to do is activate our bigger muscle fibers, even though we're lifting lower weights. I mean, that's it in a real big nutshell, instead of going super in depth on the physiology, which I would love to do. But once we're doing that, we're activating like our type 2B or our type 2X muscle fibers after repeated reps. What ends up happening is we're going through fast metabolism or anaerobic metabolism much quicker, because that's the muscle fiber type, that's the energy they like to use. So therefore, we're building up even more metabolic waste. Think lactate and hydrogen, which is going to drop your pH in your muscle belly. When that occurs, we're going to get, signals that are pressed up on our peripheral mechanoreceptor sent up to the brain, and it's going to tell our brain, hey, we're under a lot of stress down here. We need some backup. So then that's where we're going to be releasing surges of growth hormone systemically all throughout the system. But with blood flow modification or restriction training, what occurs is there's a multitude of local and systemic effects. So not only are you getting that systemic effect, you're getting that cell swelling and that metabolic stress buildup as well, which helps lead to all of those physiological changes we want, like muscular hypertrophy, increase in muscular strength, in addition to that neural hormonal cascade where we're releasing that growth hormone. And eventually down the line, we might get some IGF-1, circulating in the system, which kind of helps goes and build and repair body tissues all around, indirectly, all around our body. So Paul, you had mentioned very quickly, do you just put it on one limb? You can put it on just the affected limb. Let's just say you have a very one weakened limb. You can put it on there to try to catch it up bilaterally. But when you're using a bilateral BFR or blood flow modification technique, you're actually going to get a bigger systemic and neural hormonal response, which is going to help, potentially heal and build back faster, you know, whatever the tissues faster, what you're trying to do. So again, this is just kind of the physiology in a nutshell, but ultimately what we're doing is tricking our body into thinking we're lifting heavy weights when we're not. We're lifting very low loads, low weights, but by manipulating blood flow patterns, we can activate the muscles that would typically activate under higher amounts of stress. So this modality is definitely exhausting because you're going through a ton of metabolic stress, cell swelling, all of those other kinds of things, but we're lifting low loads. So this is a great benefit just off the top of our head for people who can't lift heavy weights or who don't want to, don't have access to it, or can't load that tissue, especially post-surgical, post-injury, things like that. So that's kind of the physiology in a nutshell, but there is a lot of local and systemic responses that help muscular hypertrophy, strength. In addition to, we're reducing venous return back to the heart. So we're going to have an increase in heart rate, and then we're going to have all these other things that are occurring that is going to be a benefit to us cardiovascular as well. So it's not just a musculoskeletal modality, it's also a cardiovascular modality as well.
Right. Yeah. And we have this association between BFR and muscular hypertrophy, but there are other, added features to this, or benefits, I should say, like, improving your uh, blood pressure and cardiovascular response, and even bone density. And we'll get into a lot of that research in the courses. But there are so many other benefits to it. And patients ask me, is this going to be painful? Okay. And so what kind of response do you give your clients? Like, you do more strength and conditioning. I see more, orthopedic patients with this. What is your response to patients who say, is this going to be painful? Should they have some discomfort when they're doing this?
It is such a great question, Paul. That is one of our top questions we get all the time. The answer is it shouldn't be painful. It should never be illicit pain. Can it bring on some discomfort? Yes, and it's going to also be determined on the level of fitness level or that someone is as well. But also, it's somewhat subjective sometimes too. If people aren't used to exercise or working hard, they might think something's a little bit more uncomfortable than not. So can it be like slight discomfort? Of course it can get, because we're building up that metabolic waste. We're drastically dropping pH sometimes within the muscle bellies. You feel that, like that burn, that really good metabolic burn, but it should never be to the point of being painful where it really, really hurts someone. So that's kind of what I usually tell individuals. But those of you or who are practitioners who want to apply this is why it's really important that you apply it to yourself first, and even maybe with some varying devices out there to see what you're going to go ahead and put on your patient or your client. And now take that one step further. Like Paul, sometimes you might have a very deconditioned patient, right? So take that, into consideration when you're applying it. But it should not be painful. It can be, you're going to get exhausted. It's a heavy metabolic workout. And sometimes you can also use BFR or KATSU training where you don't need to drastically get that heavy metabolic workout, where you can kind of just increase, decrease, flush in and out, all these other kind of things, and still get some really good physiological benefits from it. But it should never be to the point of pain. I usually take a lot of clients. I have a lot of clients that are, I like to call it strength therapy or performance, where they've graduated from PT, but they are still very, they're deficient in performance variables like agility, reaction time, and as well as a little bit atrophied sometimes. So we got to kind of bridge that gap to get them back on the field. That's typically usually where I'm at, as well as just the general population. But in short, it can be discomforting, depending on the level of restriction you go to, but it should never cause extreme amounts of pain when you're using this.
Right. One of the things I've found is that people don't have as much delayed onset muscle soreness like that next day. So you can do BFR, day after day if you want to, because you're really not breaking down that muscle tissue on a physical level like you would if you're lifting really heavy loads. And so that's the nice thing. And the other thing that I find is that people don't find it painful. They find it fatiguing. And especially like athletes who come in and maybe they're in a situation where they are non-weight bearing. They might have a meniscus tear or a fracture, and they are just geared up to work out hard and to feel like they are doing something productive. And just laying on a table there, doing some straight leg raises or doing some really light exercise is really not engaging for them. But you can start them with BFR early and really get them feeling like, I've had people, who are non-weight bearing say, I feel like I just ran a marathon. So they have that sense like they've accomplished something, which
Mhm.
on a psychological sense is also very helpful. And so you can do a lot with, less and really get that benefit out of it. So, and like, 5 years ago, I'm going to change gears a little bit. 5 years ago, there were only a couple different types of systems out there, in regards to doing BFR. A lot has changed in the last 5 years. And so, maybe we should talk a little bit about the different types of systems because, there are a lot of, different types, different ways to use them. There are some commonalities, but there are some differences also. And I mean, we go through a large section of this in the course, but just give us a little rundown on the different types of systems that there are out there, Susie, if you would.
Yeah, absolutely. So what Paul just said is what we like to do, and we really kind of go in depth a little bit more, and we love to educate on. We break down the systems in there into categories. Some general categories, and then in that category, sometimes we go into subcategories to describe it a little bit more. So for the purpose of this webinar, we really break them into 3 categories as general overview categories. And then, like I was saying, we go a little bit more nitty gritty into the specifics afterwards. But these general categories would be non-pneumatic, but also, can cut off blood flow. One, and then the other 2 are pneumatic, where you increase, meaning you're putting air into the bands at some point in time. So the non-pneumatic ones, think of like a tourniquet. Think of a belt just going around your arm and just like tightening it up. And then someone's like, hey, go estimate a 7 out of 10 tightness scale and go for it. Right. So there's, a multitude of issues that come along with that. You don't know exactly how much pressure you're putting onto your vascular system. Are you occluding for how long periods of time? Everyone's arm and limb circumferences are different, as well as everyone's blood pressures are different, things like that. So there's so many things to take into consideration. So think of a tourniquet, think of something that's non-pneumatic, not really measurable, so to speak, with the amount of air you could place into a band or a cuff. Now, the other 2 categories, which we focus a lot more in on, that we break down, are elastic pneumatic categories and then rigid pneumatic categories. And both of these, have been shown to have some really great results with BFR. But there's a time and a place sometimes to use individual ones, which we're not going to get into today. But those are the categories. So if I were to break something down into, let's just go with rigid pneumatic first, would be, let's just say I have a few examples here. So I have like a fit cuffs example here, as well as I also have a Susie system right here. So I'm just going to use a couple of these. We have a Delphi down here and things like that. But just to show you kind of, this one's a little bit wider and you can kind of almost tell it's kind of like a cuff-like material. Same thing with this. It's a little bit more of a cuff. So when you place this on the arm, when you pump them up, you're going to find first, because it's rigid. So when I mean rigid, I mean this material really has no give. Really, there's no elasticity to it. It's think like a blood pressure cuff. So when you put this on, you're going to pump up the pressure and measure the pressure. Sometimes the system does it for you, whether if it's automatic. You could also do it in a manual sense, which we're not going to get into that. But ultimately, what you're going to want to find with these type of systems are what's called limb occlusion pressure. And someone's limb occlusion pressure is the pressure, the pressure applied to the limb that cuts off blood flow to that limb. So really what we're doing, Paul, is we are cutting off arterial inflow. So there's no inflow to the muscle, and then there's also no venous outflow. So if I were to do a video Doppler, you would see no blood in or out of the muscle at that LOP. Some people also call it AOP, which is arterial occlusion pressure. Same thing. It just means you're cutting off that arterial inflow. So when you find that number, then you're going to take a percentage of that number and exercise there, because again, we want to safely restrict or modify blood flow. We really don't want to be occluding someone for long periods of time. All right. We don't need to get into the safety of it too much, but also just for subjective purposes, it's extremely uncomfortable. Think of someone taking your blood, where you have to completely shut off your blood flow and then go ahead and exercise. Blood, it's discomforting anyway.
Yeah.
So you're going to find someone's LOP, and then typically, let's estimate for like the upper extremities, you're going to take maybe 40 to 50% of that LOP. So if someone had a limb occlusion pressure on their upper extremities, let's say was 180, and we're going to take 50% of that, I would inflate this band to about 90 millimeters of mercury. We still want to allow some arterial blood flow into the muscle bellies, but again, manipulate or restrict venous outflow. We won't go too much again into the specifics of each material in the band and its effect on physiology today, but that's the gist of these. You need to find LOP because this can cut off arterial inflow. Now, the next category of the pneumatic bands are, and then Paul, you can show an example of the ones that you have over there, but I'm going to show here is their elastic pneumatic bands. So something that's elastic and pneumatic is, and I have a Katsu Bluetooth B2 right here as an example, and Paul over there has a B-Strong band example over here, as well as I have a Katsu band that's also goes with the C4. So there's different versions of these bands. What these do is when you inflate them, no matter how much pressure you're putting into the band, you can put up words near like 400 millimeters of mercury, think about, or standard Katsu units, which is just representative of millimeters of mercury. You're still going to be able to find some arterial inflow as well as, but you're just manipulating venous outflow. So you're not going to be able to occlude. So the elasticity to the tissues, or excuse me, to the bands means that there's a little bit of give to the band. So every time you flex and extend, it's not cutting off arterial inflow. So the point of these are, just, depends on if you want to dive into the various companies and things like that. But the original Katsu systems, like I said, that was developed in Japan, where this kind of whole modality came from, was not to impede arterial inflow. They want arterial inflow into the muscle bellies, but to manipulate venous outflow. So there's, again, elastic pneumatic, and then you have the rigid pneumatic bands where you would need to find LOP and then take a percentage of that and exercise there. So much more to it than what I just said. However, those are the kind of the categories, and it's usually good if you can get to a demo or to an in-person course or to something to get your hands on some of the different ones to see what would be best for you. But also Paul and I are more than welcome to always, anyone who's listening to this webinar, to ever set up a meeting with you and really go much more in depth if you're like, you know what, I really want to get some for our practice, but I really have no idea what direction to go into. That's why we're here. We're happy to do that. But those are the main categories of what we like to break into the bands.
So I want to jump into the different types of people, patients, clients, athletes utilizing this. Now, we heard that Katsu's been at the Olympics, correct? And so we have athletes who are utilizing blood flow restriction. Can you explain how athletes at a really high level like that utilize BFR? And then I'm going to talk about how I utilize it with certain patients and certain diagnoses. So I'll have you start with that because the Olympics are happening right now, and we know that they're utilizing different systems. And why would a high level athlete who has a lot of hypertrophy want to use something like BFR?
Yeah. Oh gosh, this is such a great question. So yeah, let's take it from a high performance standpoint first. There's a multitude of ways you can use either Katsu or BFR training as a high octane athlete. We get that question all the time, where I've had professionals come up to me and say, hey, I see this really in a great spot for rehab, but I really don't see it for my athletes or my strength and conditioning athletes. Well, couple things I love to use either Katsu or BFR with is during, I like to call it icing on the cake situation, or active recovery days, or right post a workout for recovery, or even for a warm up. You can actually use it to warm up your cardiovascular system, your muscles. There's just a multitude of ways you could do it as an athlete that's uninjured. But let's just dive into another example of, let's just say, I'm going to use it. I use the terminology icing on the cake. So let's say a traditional athlete is lifting heavy weights, going under the bar, lifting heavy. Your football players need to know how to lift heavy. Other places, there's a ton of benefits for, you still need to lift heavy weights depending on your sport, and all those kind of good things. But where you could get that extra metabolic boost or that neurohormonal response will be at the end of that exercise session. So say you did a heavy lower leg day, and you did, 80 to, 85% of your 1 rep max for your sets and things like that. Right at the end of your session, you can put some bands on and perform a little bit of a metabolic workout where you're doing low loads, low intensity, but higher amounts of reps to get that extra metabolic activity occurring, which is then going to lead to that big neural hormonal response, which can then later lead down to some a little bit better tissue healing and recovery. The other ways I like to use it with my athletes where it's on recovery day. So if they have a low active recovery day, throw some of these bands on, either do some cycles, do something like that will really help kind of build, heal, repair those tissues during recovery. So great way to use it there as well. So yeah, so there's a number of different ways you can use it. We also use it a lot with the aging population, just health and longevity in general, to just build up some muscle mass or some strength, or also, like you mentioned, the lowering resting heart rate, lowering resting blood pressure, number of health benefits to it too, not just performance or rehab. So those are just a few ways you can use it, definitely for recovery as well, for warm-ups or icing on the cake. I mean, the beauty of this modality is that there's so many uses for it, from post-surgical injury all the way up to the highest level Olympian that's going out there right now. So if you do want to shoot, the Katsu right now, has a great, has their page on some of their Olympians using it, which is pretty neat. So, so that's kind of just a couple ways you can use it in that sense. But I'm going to kick it to Paul so he can talk about some of his clinical case studies and his success stories there.
Yeah, I don't even know where to start. I'll go with my last patient that just came in recently, a couple weeks ago. She fractured her fibula, distal fibular fracture, and a syndesmotic injury. So that put her into a non-weight bearing status. An athlete, likes to push, very aggressive, lots of grit. And we started her off on BFR and absolutely loved it. And so we use that pretty much every single time she comes in. And to be totally honest with you, she was non-weight bearing for about 4 weeks, and there's very little atrophy. It's just amazing. And we're able to push her hard. She's getting a great cardiovascular workout while she's utilizing this. And we're not in weight bearing. Okay. So we can do a lot of that stuff. I've seen patients with meniscus repairs who are non-weight bearing. Tibial fractures where, if they want to start with, 10 to 15% weight bearing or light activity, we can work around that. We can put the BFR on the opposite leg. We are utilizing it for anything Achilles reconstructions after a rupture, your tendinitises, your tendinopathies. We are doing it. I've had people with distal bicep ruptures. We've had humeral fractures. I had an 83-year-old lady recently with a Colles fracture. We started her right away. She started with us at 2 weeks after surgery, and we utilized BFR almost the whole time she was with us. I've got some great videos on that. Had a great response. We were able to press her along nicely with very little discomfort, and she was a very active woman too. And so she wanted to be pushed, but obviously we couldn't push with lots of weight bearing or heavy weight at the time. So we just jumped into the BFR right away. And so ACLs, I've had quad ruptures we've used it on, because obviously you can't do heavy knee extension. There was this long period of time for many years where PTs were not pushing ACL patients into terminal knee extension in the open chain. And I never really kind of followed that, but we had to go really, really light with these folks. Couldn't do a lot of pushing, but with BFR, you can put a 5-pound weight on that ankle, do open chain knee extension with the BFR. They feel like they're pushing 100 pounds. They're getting a great workout and they're getting good activation of that quad. So we're utilizing it with that. I mean, it's endless. I'm using it with back pain patients. And I have a lady who was doing CrossFit. She just recently herniated a disc, L3, massive herniated disc, to the point where she was having significant quadricep weakness and hip flexor weakness. Decided to go the non-surgical route and was starting to see some slight improvement, but had that desire to work out every day of the week and push hard. So we threw some BFR on her, and in about half an hour, she'd felt like she'd been doing an hour and a half in CrossFit. Light loads, doing some core stability, multi-directional hip strengthening. trying to regain that quad and hip flexor a little bit with really light weight and feeling like she got a great workout. Right now, her quad and hip flexor strength are at 4+/5. She's just about there in regards to her strength. And you know, some of these folks, they don't have time for a long workout. And so what we might do is give them a little condensed regime for 15 to 20 minutes with BFR, and they feel like they've had an hour's worth of workout. So we've seen those, you've seen those people, Susie, where they come in and they're like, listen, I want some sort of a fitness program, or I don't have a lot of time. I'm busy. I have 3 children. I work a full-time job. I have a 20-minute block that I can dedicate to myself in the morning. What can I do? And those people all get BFR because you can really knock out like 3 or 4 exercises and get a great workout out of it in such a short period of time. So those are some of the folks that I see, that I use BFR. I use BFR almost every day with folks, and there are just so many benefits to it. So safe. I haven't really seen any issues. I think maybe one person had an active blood clot, so we deferred using BFR with that person. They had used that BFR in the past for a previous injury, and they were begging to use it. Most people, after they've done it a couple of times, they're like, okay, let's do that again. That felt great. And so a lot of people have turned the corner, especially those people who you just can't load yet, but you still want to get things active and working. They will do well with BFR. Those who need that psychological, push, it works great for that too. So those are some of the different types of patients that I've used it on for optimizing their care, especially soon post-op. And I typically would like to wait about 2 weeks, no matter what the injury is or what the surgery is. I like to wait about 2 weeks before starting BFR, just so that they can get comfortable with themselves and get the pain under control and whatnot. And then we start to utilize it. I've actually utilized it on people who have like knee swelling, who've had chronic knee swelling, and we use BFR, and it seems like in that time that we start utilizing it, the swelling goes down faster.
Yeah.
And so there's this flushing effect that happens, and we found some very good benefit. Didn't interview, but we gave a tour to a new orthopedic surgeon yesterday, and she came in and says, "Are you guys doing this restriction type stuff?" And I said, "Absolutely." And I gave her, I explained it all to her. She wants to come in and try it out herself. And we are actually giving live courses to folks who are requesting the live courses because orthopedic surgeons are asking therapists to do BFR with their patients. And if they haven't done it before, they don't really feel comfortable. They want to be able to say to that orthopedic surgeon, "Yeah, we're doing it, and we're comfortable with it." And so that is something that is just coming up. It's becoming much more popular in the realm of orthopedics, and we're utilizing it a lot more by request now. Not only from patients who are learning more about it because of the great benefits, but we're also, getting requests from physicians and providers to utilize it with the patients. So I don't know from your end, are you seeing that also,
Oh
Susie?
yeah, I mean it's funny since I've actually been like researching. I did my dissertation on BFR. I've had a bunch of studies going, how we got connected. I went to go speak for Dr. Christian Latterman's orthopedic staff on this years ago. That's how we ended up getting all connected through all of this. But it's funny, even 5, 6 years ago, 7 years ago, when I mentioned, oh, this is my specialty, this is what I do, I go around and educate people on this in a comprehensive format and things like that. A lot of people still turned away from it because it was still so novel back then that it's like, but now that's being accepted by the masses a bit more. Now people are like, I'm hearing about this more and more. Now I want to learn about it. So there's a lot more there. But when you mentioned something about like the fitness aspect, when we want to kind of look at post-surgical non-weight bearing things like that, you've used it, we've used it, and I've worked with PTs in conjunction with them, especially who aren't super familiar with it. They usually consult with me on it, where we've used it, especially if you can't compromise the integrity of the surgical site. Let's use a knee surgery, or you can't bend the joint ankle at a certain period of time. You can use neuromuscular electrical stimulation in addition to BFR or KATSU or altering blood flow patterns to get that involuntary muscular contraction, in addition to the alterating of the blood flow patterns. So we're starting to really see a drastic decrease in the percentage of atrophy. Are you going to get some? Yeah, it's disuse. You're not on it. You're non-weight bearing. But the drastic difference between someone who's not doing that comparatively to someone is kind of crazy. And then we'll take it from the other extreme, like you had mentioned. People have no matter time. I've had a bunch of moms or bunch of, women who used to be athletes or just not even not athletes who just love to work out, but are like, I have all these kids, full-time job, all the time. I have 15 to 20 minutes to myself, but I really want a good metabolic workout, a good cardiovascular workout, musculoskeletal workout. How can I do that? And that's where I'm like, all right, let's hop into a program for you, ease them in, and they're off and running on that. Paul, I know you and your wife use it as well. My husband and I use BFR a lot of the time for our own fitness. We have a 2.5-year-old and an almost 5-month-old, and we're both full-time working and all these other things. So time is definitely very limited, but we still put our health and wellness and fitness as number one. So sometimes it's great to just get a 15 to 20-minute workout in, but get this huge physiological response. In addition to, we have some individuals who don't want a traditional type of exercise program. So I said, and they're like, well, I go, what do you like to do? That I like to walk my dog. I said, okay, throw the bands on your legs, walk for 20 minutes with your dog and see the difference in a month, see what happens. And I can't even tell you how many people I have right now just using it, walking their dog. And it's crazy, or just walk uphill for a little bit or something. You don't need to always have, the traditional protocols that we do teach. Just so many uses for it that we could just continue. This webinar could turn into an 8-hour course.
Right.
But that's just kind of showing you the drastic differences and, of populations that can benefit from all of this.
Right. So what I'd like to transition into is, you've put a tremendous amount of time into an online course. I've helped you with that, and we've done some live courses. The online course is super comprehensive. Before we get done here, give me a quick rundown of how the course is broken down. And then we'll kind of go from there. But in a nutshell, what do we have in this course that everybody wants to see? Number one, it's a non-biased course, right? So we don't come in with one particular device and say, this is the only device you should use and all the rest are bad. We talk about the benefits, the pros and the cons. I have reasons why I use certain types of bands. You have reasons why you use certain types of bands, and it might be the type of clinic that you're in. It might be the fitness facility that you're in, the need, the patient population. So we kind of, lay that out, but give us the outline of what this course looks like and what people are going to leave with when they're done with it.
Yep, absolutely. So, I mean, pretty much the in-person and online course almost mirror each other. The online course, is fully comprehensive, as is our in-person 1-day full comprehensive certification course. But the online course, you go through you're going to go through a bunch of modules, and what we really start off with the introduction to us and where we come from, our experiences. We dive into what this whole modality is. We really give a really good thorough review of the history of where the modality came from. And we kind of break into then the different terminology, say, hey, like this is this kind of terminology, and this is where you would use this, where you wouldn't use that. And then we head right into kind of a little bit of the physiology of deconditioning and atrophy, as well as the state of the health of the world, and more specifically the United States. And then from there, we do a really good review, or I consider it a really good review of a muscular physiology review, just in general terms, from if you were to lift heavy weights or exercise at a high intensity. We do a really good almost ex-phys muscular physiology review, because then it's easier when we go to module 3, where we're talking about BFR physiology. It's easier to connect the two once you review basic physiology, because I've done that in the past where I just dive into BFR physiology. Then there's so many other questions regarding normal physiology. So
that worked out well for me when I went to your original course. It's like, I'm not strong in physiology, and that's why you and I have connected. You have the strength in physiology. I do a lot of practical application type stuff. And I'm not strong in physiology, but you were able to make it very clear, and it transitioned nicely into the BFR physiology, and it kind of brought back these, nightmare classes of mine. But it was understandable, and I hadn't utilized a lot of that terminology in a long time. But we break it down and make it a lot easier to understand and make it flow into where we go next.
Yep, absolutely. So it just flows right into then what occurs physiologically under BFR, or Katsu modification training. And then from there we head into kind of a device review, where we do the categories. We say, okay, just kind of, we gave you this brief overview right now of the different categories. We dive in. We use video examples, especially in the online course, but in the in-person courses, we bring all the equipment, so you get to see a multitude, almost everything that is out there. You get to put your hands on and see kind of the differences of, the different types of tech, bands, feel, material, all of that. So we kind of do a little dive into the description of the 3 different categories, and then take a little bit better look there. And then from there, we talk about a lot of research, a lot of the research that's out there in practical applications, and some key studies that Paul and I think were really important to bring to you. There are now hundreds, if not thousands of studies on BFR now. So we obviously can't go through all of them. That would be quite boring. So, however, we give some really good highlights and some summary points of some really good research in the direction that, the field may go in, or we may look into. And then from there, we kind of go into like safety, efficacy, things like that. So like the do's and don'ts of BFR, the where would you not use it, where would you use it, how to safely apply, things like that. And then from there, we go into the application protocols, and we kind of go over all of the typical protocols that are out there for varying populations, the aerobic protocols comparatively to musculoskeletal, things like that. And then lastly, we dive into a little bit of beginning with BFR and like exercising. So if you're with us in person, you dive in and you exercise with us. If you're able-bodied and healthy and ready to go, like you try it out and you get a good sweat on, and everyone, works out at the end. But then also in the online course, we provide examples for you to be able to join in with us, and things like that. So those are kind of how it all flows. We go from all the way from the intro to history, what it is, all the way to practical applications and how to apply it.
Yeah. So when we do the live course, we are able to answer a lot of questions as we go. It's a very casual course. There's nothing, if anybody has questions, they ask those questions. We answer them to the best of our ability. And we do get questions on occasion about unusual diagnoses that we may not have used it on yet. So we do a really good job at trying to get out there to try to get that information for you and bring it back. Now, let's say you're doing the online course and you have questions. We are more than happy to, connect with you afterwards. You can you send us an email. We could do a quick Zoom meeting, answer those questions for you, just so you feel like, you feel 100% comfortable when you're utilizing BFR when you're done the course. So we've never had a live course where we have just cut the cord at the end of the course and said, okay, you're on your own. We have fielded questions. We've been fielding questions for the last 3-4 years from courses we've done in the past, just because something unusual might come up and somebody has a quick question. We're more than happy to answer those and stay connected, just so that we can keep you comfortable doing that modality and utilizing that new tool that everybody wants to do and add to their toolbox. So now, if you're interested in the course, be sure to click the link in the show notes. We will have a link to Susie's page. If you want to look at the description, outline of what it entails, you can do all of that on the website. Just click on that. But be sure, if you do sign up for the course, utilize our coupon code. It's OEP. It's OEP BFR, and you get a $300 discount on the course. So take advantage of that. If you are interested in a live course, be sure to connect with us. If you want to host a course, there are a ton of benefits to doing that, because you don't have to send your whole staff away, because that can be quite costly in regards to hotel rooms, food, time away from work. You got to shut down a clinic. We have gone to different clinics so that they can bring everybody together. Significant cost savings, and it's live, it's in person. You get to try all of the different devices, go through some of the exercise programs, and we just really can connect doing that also. But we've had many people say, I'm sorry, just can't make it to a course, it's too far, or just I can't get away. I'd like to do this over the course of a week or 2 weeks and just break it up in modules. Then the online course is for you, and then you can just do it piece by piece as you go along. And we can get folks CMEs, correct, Susie, and BOC credits for this.
Yep, absolutely. We have, like you just said, you can get it's been approved for CEUs to the APTA. I'm a BOC provide class training education is a BOC provider. So athletic trainers can receive CEUs for this course, as well as we'll be putting it through a number of different organizations. Hopefully, we've had people put it through taken some of the, the objectives and so forth and put it through themselves through NASM, through that for personal trainers, things like that. And you can apply it through for CEUs as well. So there's definitely an extra educational benefit to taking the course either in person or online.
Yep. Well, there you have it, folks. An 8-hour BFR course in a nutshell, just to give you some idea of what we do in the courses that we give and how we apply it to our clients and our patients. And we hope to see you soon. If you have any questions, shoot us an email. I'll have Susie's email in the links. I'll have my email in the links. Feel free to take this webinar link and send it over to your colleagues and your friends so they can take a look at it also. And we hope to see you in the future. Take care.
Awesome. Thank you.